Thank you very much for the kind invitation. I'd like to thank the organizing committee to invite me to present this lecture. This is a field that's growing in interest, and especially for the surgeons here in Asia, as colorectal cancer is increasing in incidence. In fact, there's an epidemic of colorectal cancer in the East. If you look at what's going on here at our institution in Houston, you see that we have increased tremendously the number of patients who undergo a liver resection for colorectal liver metastasis. In 2006, from our medical oncology database, 25% of the patients with metastatic colorectal cancer, that's the entire group, not liver-only colorectal cancer, but metastatic colorectal cancer, but the whole group, you will see that 25% undergo resection. That includes patients who present to us with lung metastasis. Now, the problem with liver resection for colorectal liver metastasis is that you can be disappointed. And you see that well illustrated in these two patients. You have the first patient in this first line here, who is a patient who had a single liver metastasis, responded to chemotherapy in terms of RECIST criteria by downsizing, but you could see after resection, you have a lot of viable cancer cells. This patient had RAS mutation, and this patient died within 17 months. Conversely, you see this patient with this large metastasis here. This patient even had a portal lymph node that was positive. And this patient underwent chemotherapy, did shrink also, had a RECIST response with shrinkage, but you could see the tumor became dark, homogeneous. There was a very good cell kill with very few cancer cells left in the specimen. This patient was RAS wild type, and in fact is alive now after an extended right hepatectomy after a median of 60 months follow-up. Very different presentations, so I would submit to you today that we have, in fact, subsets of patients with metastatic colorectal cancer. And you can sort the patients in terms of these subsets by looking at the response to therapy, looking at the pathology after liver resection, and finally, looking at RAS mutations. So we'll talk about the role of chemotherapy in the modern era. We'll talk about expanding resectability, and I will be very brief on this. Tomorrow morning, there is a breakfast, Meet the Professor, where we will talk about expanding the resectability in patients with very small liver remnants, so I will not dwell on it. And I will talk to you about the emerging role of mutations. This is a slide that should be known for you if you treat patients with colorectal cancer. Natural history of survival used to be median 6 months. It went up to 13 months with 5-FU capecitabine. The cytotoxic agent came, irinotecan, oxaliplatin, adding on survival. Finally, targeted agents, cetuximab and bevacizumab, were added with a little bit of improvement in survival. That's level 1 evidence. That's treatment of metastatic colorectal cancer in medical patients. We have this evidence of survival. We don't have evidence of survival for patients who undergo resection of colorectal metastasis. However, there is consensus now that these patients should be treated. In our institution, we treat these patients preoperatively with a short course of chemotherapy. And you see now that 85% of patients at our institution receive chemotherapy, whether they are resectable or unresectable at presentation, receive chemotherapy, if possible, short course. You can see here that we have decreased the number of patients who receive prolonged chemotherapy, and it's better because of the liver injuries. you see that the major hepatectomy, half of the patients receive still major hepatectomy. We still do a lot of extended hepatectomy, 20%. Chemotherapy can be bad and can be good. So you have to sort this out. Basically, you can have two types of liver injuries. A blue liver, if you extend the chemotherapy, usually for many months, or you can have a yellow liver. That's particularly true in the United States, particularly in Texas, where patients have very high BMI. Please note that 5-FU can also cause steatosis. If you need to know something about chemotherapy-related injury, this is very simply presented in these slides. Irinotecan can cause steatosis, steatohepatitis. The risk is increased mortality from liver failure. It is thought that irinotecan can cause a second hit in patients with steatohepatitis, in steatosis, causing steatohepatitis. Oxaliplatin injury has been well described, causing sinusoidal dilatation, and there is an increase in perioperative transfusion, particularly in patients who have received more than 6 months of treatment. How long should you wait between the end of chemotherapy and the surgery? This is a study from the UK. These patients were not receiving targeted agents or bevacizumab, but the consensus is that you should wait between the last dose of chemotherapy and surgery at least 4 weeks to optimize the result of surgery. Now, what happens when you give chemotherapy to patients? You have 3 situations. You can have a complete response, 10% of the patient. You can have a major response, 40% of the patient. And you can have a minor response, where between 50 to 100% of tumor cells are still present under the microscope. Now, 7 days after surgery, we have pathology reports giving us the result of the response. And this is important because it correlates with the survival. And you can have a meaningful discussion with patients about their outcome. Please note, however, that patients who have minor response still have a chance at long-term survival. If you look at the traditional colorectal risk score and the information given based on the response to chemotherapy, you will find out that, in fact, response to chemotherapy, pathologic response, as defined by chemotherapy, outperforms your usual criteria. And you remember we used to, at bedside, determine whether the patient had positive nodes, whether the patient had high CA, etc., size of the tumor. What determines the outcome is really the biology. You can look at the films, especially in patients who receive bevacizumab, and you can find in some patients, about 40% of the patient, this optimal response. If you have good CAT scan, you can see this response where the tumor becomes cystic. There is no enhancement at the margin of the tumor. That corresponds to fibrosis. This is not necrosis. You have an intermediate response here, and you have this, which is a de novo presentation, where you have the necrosis here because the tumor has outgrown its blood supply. You have very different survival outcomes in patients who have this cystic response. This cystic response leads to an improvement in median survival of about 12 months. That's very important. That's from 19 months median to 31 months median, 12 months. And you can assume that based on the reading of the imaging. If you look at RECIST, when you have a shrinkage of the tumor, you do not necessarily have a better survival, in fact, by having a great shrinkage. We've looked at 209 liver resection, now looked at this optimal morphologic response, and in fact, it's associated with a great survival here, more than 70%, but more importantly, you have a twofold increase in recurrence-free survival. Remember, we don't cure the majority of these patients, but it's important to recognize this type of response because it's probably associated with treatment of micrometastatic disease. How do we expand resectability? There are many methods of expanding resectability. There will be talks on ALPS, debates. I don't want to go into this discussion in detail, just to tell you that if you use portal vein embolization, you should use the right technique. If you plan to do an extended right hepatectomy, you should embolize the right portal vein here and the branches to segment 4. And you should have good interventional radiologists helping you in driving this regeneration. You see in this patient 10% to 33% liver remnant. That's more than 100% increase. And in fact, these patients do well after surgery. So you have this subset of patients now. They can undergo chemotherapy, hepatectomy, chemotherapy. That's called perioperative chemotherapy. You can do a PVE also. You can do 2 hepatectomies within the confines of chemotherapy. And finally, you have the 2-stage with the portal vein embolization in between. Please note that this is a small number of patients, about 10%. It's not a large number of patients. What is the outcome of the 2-stage strategy where you start by resecting tumors in the left liver and you follow by resection of the right liver? Well, on an intent to treat, you see that the survival is pretty good. It's about 51%. And you will see that for patients who completed the scheme of 2-stage chemotherapy, survival is even higher, 65% at 5 years. Patients who do not complete the complete scheme have a survival that's even lower than best chemotherapy. Now, what about margins in the context of chemotherapy? Well, recently, there was a discussion here, especially in this paper. Please ignore this one, but look at this paper here, where it was said that, in fact, you could probably resect patients with R1 margin because the survival was just as good as patients with R0. We have looked into this question at our center, and in fact, we still found out in the area of chemotherapy, especially irinotecan and oxaliplatin, with or without targeted agent, that margins matter. So I think the word is not out yet, and we should still consider margins. And this problem is certainly very serious in patients who have minor response to chemotherapy. You could make the case in patients who have major or complete response. In some of these patients, in fact, will have a survival that's identical to patients who have an R0 resection. So in patients with major or complete response, expansion of the resection criteria to no margin could be considered in some patients. What about the role of mutations? This is as complicated as the subway of Tokyo. You see this cascade of colorectal cancer, and it's very complicated, but can be simplified. There are 5 driver mutations: KRAS, NRAS, PIK3CA, PTEN, and BRAF. They are called driver mutation because they seem to drive the biology. Up until recently, only KRAS was thought to be important, and in fact has been used by our colleagues in medical oncology to predict a better response in patients with wild-type KRAS, and this better response was associated with an improvement of progression-free survival. Now, this can be expanded to surgical patients, and I'll just describe RAS mutation because that's the most important here. RAS mutation, KRAS mutation can be expanded into surgical patients. RAS is an early event, is like a birthmark in the genesis of cancer. So T1, T2 tumor don't have less RAS mutation than T3, T4. It's a birthmark of the tumor. Number two, there's a concordance of RAS mutation between the primary and the metastasis, so that if you have a resection of the metastasis, you can infer that the specimen you will resect in the liver will have the same mutation, RAS mutation. This is the concordance in several papers. We have looked at 193 patients who underwent liver resection, looked at their RAS mutations and other mutations in their liver specimen using polymerase chain reaction. And we found out that in a group of patients who had only first-line chemotherapy, so fairly favorable patients who then underwent resection after chemotherapy, the rate of KRAS or NRAS mutation was 18%.